mucinous cystic neoplasm, this rare tumor that is seen almost exclusively in women, actually middle-aged women, that is located 95% of the time in the body and tail of the pancreas, that is always a single lesion. Well known. There was confusion between this and branch duct IPMNs for many years. Now we know we need to have a stroma layer to call this a mucinous cystic neoplasm. And there's really not a lot of debate or a lot of difference from what we knew and what was recommended originally. And that is that surgery is recommended for all surgically fit patients, even though the risk of invasive cancer is only 15%. And why do we recommend surgery, or why is surgery recommended? Well, these are women in their 40s or their 50s. Are you really going to watch them for the rest of their lives every 6 months? We have really no way to predict, at least as of now, and maybe things will change, which ones are the ones that are going to become the invasive cancer. And when this becomes invasive cancer, it could actually be as bad as regular pancreatic cancer. The guidelines also ask to consider parenchyma and spleen preservation as well as laparoscopic surgery for lesions that are less than 4 centimeters and devoid of nodules, because we know these lesions do not have invasive cancer. So the caveat here is that this assumes that we're able to make the diagnosis of a mucinous cystic neoplasm. And I'll ask everybody here in the audience, is every single cystic lesion in the distal pancreas of middle-aged woman MCN? And the answer is clearly, well, no. Take a look at this one, for example, that we took care of a couple of months ago. There's a 39-year-old woman who has this incidentally discovered 2.8 centimeter cyst in the tail of the pancreas. You look at this and you tell the resident and you tell the fellow, this is a mucinous cystic neoplasm. It's a no-brainer. Well, we did a laparoscopic enucleation. You can see there that the lesion was almost like hanging from the pancreas. And the pathology shows a 3-centimeter well-differentiated cystic neuroendocrine tumor. So we thought this was not the right operation for her, so we reoperated, did a distal pancreatectomy and splenectomy, found no residual tumor, no lymph nodes, but we felt more comfortable doing this operation than what we had done before. The second easy one to deal with is main duct IPMN. And it's easy because we, again, all pretty much know what to do. Like in 2006 and 2012, the guidelines say that surgical resection is strongly recommended for all surgically fit patients because the average risk of malignancy in this condition is 62%, and the bulk of these are invasive cancers. And there is no reliable way to rule out this cancer. So there's no symptoms, there's no marker, no reliable biopsy that will tell you the patient does not have cancer, and therefore we recommend resection. The guidelines say something new and say that milder forms of main duct dilation, that is between 5 and 9 millimeters, are not always main duct IPMNs. Sometimes they're branch duct IPMNs, and the dilation is due to the mucin. And the risk of malignancy, actually, when there is main duct IPMN, may actually be less. So there's some studies from Japan and from Korea, and you can envision that you got an 80-year-old, maybe sort of fit, but not completely fit, and he's got a main duct IPMN, and maybe the dilation is only 7 or 8 millimeters. Well, maybe that's one that you may be able to watch and not fear that you're leaving behind an invasive cancer. There's also a word of caution in the guidelines, and we have learned this with experience, and I think most of us who have operated on these patients every now and then have taken something out that we say, oh, this is a main duct IPMN, and guess what? Well, there's no IPMN, right? And there's also no chronic pancreatitis. There's this sort of idiopathic dilation of the main pancreatic duct that we see occasionally, and so it is recommended whenever we make this diagnosis and we're going to act on it, that we actually get an ERCP, a study that we used to do in the inception of IPMNs, and that we all nowadays don't do that often, to indeed confirm that there's mucin within this tumor. The other word of caution in the guidelines is to have careful intraoperative assessment of the transection margin. The goal is not to have a margin that is negative for IPMN, but certainly the goal is to have an IPMN margin that is negative for high-grade dysplasia or for invasive carcinoma. So here we come to the real problem, and this is the management of branch duct IPMNs, which is by far the most common of these lesions, by far, by an order of 8 or 9 or 10 to 1, and one that all of us here, I'm sure, see in our practices and are asked to give an opinion on what to do. This is the algorithm, and I'm not expecting you at 6:45 or at 10 a.m. to go through this, but I'm going to summarize a little bit of what is said here. So let's start with the original guidelines, the ones that were published 6 years ago. And the original guidelines said that observation for asymptomatic patients with branch duct IPMNs less than 3 centimeters that had no nodules and had no main duct dilation, and the main duct dilation was defined as 6 millimeters in 2006, was okay, and that these patients could be followed. And a lot of us actually modified our practices based on this. And I will tell you that since 2006, there's at least 12 series in the literature that have validated the safety of these guidelines. How do you validate this? Well, there's 2 ways to do that. You look back at all the branch duct IPMNs that you removed and say, well, let's see if it's true. Let's see if there's no nodules and there's no 3 centimeters, and look at the history of those patients that had no symptoms. Let's see if it is true that there is no cancer within them. And many series have validated this. But the other way to validate them, of course, is prospectively. Okay, if this is true, we're not going to operate on these patients. We're hoping these patients are not going to start to die of pancreatic cancer. And in fact, there's many series that are prospective that have done that. So this, for the most part, has been good. However, all these series, looking back, have also shown that the majority of patients that we end up resecting following these guidelines actually have benign disease. So we may actually be overacting on this. The new guidelines stratify these lesions further, saying the ones that have no risk, but the ones that we used to consider risk, into 2 groups. One called high-risk stigmata, and another one, lesions with worrisome findings. High-risk stigmata are jaundice, an enhancing solid component, a main pancreatic duct more than 10 millimeters. In all these patients, the guidelines strongly recommend resection. In our experience with 700 branch duct IPMNs, about 250 operated and the rest under observation, these features, high-risk stigmata, are very rare. Less than 2% of the patients have this, an enhancing solid component, jaundice, or a pancreatic duct of more than 10 millimeters with a branch duct IPMN. But interestingly, the bulk of these patients, in fact, do have invasive cancer. So this is a good thing. You know, that's a small fraction. And then comes the other category, worrisome features. And worrisome features are when a cyst is greater than 3 centimeters. Remember that in the past, they would recommend surgery for these. A thickened, enhancing cyst wall, a main duct between 5 and 9 millimeters, a non-enhancing mural nodule, or an abrupt change in main pancreatic duct. So these things are worrisome, but they're not in the same category as high-grade stigmata. And what the guidelines say is that these patients are recommended to have endoscopic ultrasound to better define nodule and for cytology. And this is an interesting change. So in 2006, endoscopic ultrasound is not even mentioned or barely mentioned in the guidelines. And in this jump 6 years, of course, with the push and the input of many gastroenterologists and surgeons who work with gastroenterologists, this comes up. And so it is recommended to have the endoscopic ultrasound to analyze these things better. What can endoscopic ultrasound do? Well, confirms if the nodule is present, although we have to be careful for reasons I will tell you. And if the cytology, if the nodule is present or cytology is suspicious or positive, or there is main duct involvement that can be seen by endoscopic ultrasound, which we sometimes can see, then resection is recommended. And if not, surveillance. In our experience, worrisome features are much more common than high-risk stigmata, of course. 21% of these patients had it, and actually 97% of these patients were operated on. So these were the patients that we were up to 2011 resecting. And if we look at this 97%, again we find that about 30% indeed have high-grade dysplasia or invasive cancer, but 70% do not. So what we have is parameters that are very sensitive but not very specific. And what is the bottom line? I'm not going to go through that complicated algorithm that I showed you. The bottom line is that if you have jaundice, real nodules, and duct dilation of more than 10 millimeters, this is very concerning. And I say real nodules because we, for example, at MGH looked at this issue. And half of the time that an endoscopic ultrasound, and this is not just endoscopic ultrasound at an MGH, because now endoscopic ultrasound is done everywhere. You know, small community hospitals have endoscopic ultrasound. Half of the time, when a nodule is called by endoscopic ultrasound, the pathologist cannot find it. So these are not real nodules. So they have to be real nodules, and that's why you have to see if it enhanced or not. And the bottom line is that size is de-emphasized. The 3 centimeter mark no longer sort of happens. And endoscopic ultrasound is now recommended for worrisome lesions and as well as part of the follow-up for lesions 2 to 3 centimeters. That is, not for all. And this is an important paradigm because our knee-jerk reflex is you got a cyst in your pancreas, you need an endoscopic ultrasound. Well, you know, we could have a whole conference of 2 hours on what endoscopic ultrasound can and cannot do for this problem. But certainly for the bigger lesions, more than 3 centimeters if we're going to watch it, or 2 to 3 centimeters, I think this is a reasonable thing. Now, like anything else, this is a consensus. That doesn't mean that there's universal agreement on this. The caveat, of course, is endoscopic ultrasound is operator dependent, and as everyone in this room knows, cytology in this field is tricky. And it's tricky because the needle goes through the stomach, it goes through the duodenum, it carries those cells. The cytologists are hedging often on these things. Unlike solid lesions where it is exceptional to get a false positive result, in cysts, it's not that rare to get, you know, positive for adenocarcinoma and there's nothing. So it does happen, and endoscopic ultrasound is not perfect. So what do we do now that we've decided not to operate on a branch duct IPMN? Well, the guidelines say that in all patients, once you've made the diagnosis and you say, well, this doesn't need EOS, this doesn't need surgery, you should do a short interval. That means 3 to 6 months, either MR with MRCP or CT scan, whatever your local preference is or whatever is better in your institution. And following that, for lesions that are less than 1 centimeter, and of course these are the majority of them, every 2 to 3 years. If the lesion is between 1 and 2 centimeters, every year. For lesions between 2 and 3 centimeters, as I said, endoscopic ultrasound alternating or getting an endoscopic ultrasound in 3 to 6 months and then an MRI every 6 to 12 months. And now here comes the tricky part. For these worrisome lesions that we were watching, the ones that were greater than 3 centimeters, the guidelines went extraordinarily conservative. They said alternate MRI and endoscopic ultrasound every 3 to 6 months. Is this doable? Is this realistic? Who knows? Clearly, there is concern that we're going to be missing some cancers. You want to be able to pick them up. So it is unclear on the also in these guidelines what is the endpoint or if imaging can be spaced further after many years of follow-up. Okay, I follow this cyst that is, you know, 1.3 centimeters. I've been doing yearly MRIs or yearly CT scans, and it hasn't changed. It hasn't changed. It's been 5 years. Can I stop following it? Well, we don't really know. There was a paper about 1.5 years from France showing that these lesions could be stable for 8 years and then suddenly progress and become cancer, a small fraction. So the bottom line is we do not know, and we badly, badly, badly need information on the natural history of this condition. So I cannot finish this talk without mentioning these 2 papers. And this is literally hot out of the press. This is a paper that was published last month in the Journal of Gastrointestinal Surgery. It was presented last spring in DDW in the meeting of the SSAT. And the title is certainly provocative, right? High-grade dysplasia and adenocarcinoma are frequent in side branch IPMNs measuring less than 3 centimeters on endoscopic ultrasound. And the other paper I need to mention is this one that appeared last year in Annals of Surgery. It was presented 6 months prior to that in the American Pancreatic Association. Small, Sendai-negative branch duct IPMNs, not harmless. Certainly titles that would, you know, pick anybody's attention, and in fact, pick up the attention of patients and referring doctors. I really think that there's a category of papers that need to have something like this, you know. You gotta be careful what you read there, and especially patients. You know, you read this, and a patient is not gonna read the whole thing, and I had a patient literally come to me and say, I cannot believe you said I could watch this. Look at this. You're telling me that my risk of cancer is 25% and you're going to watch this? So it takes a little bit of explaining. So let me just dissect these 2 papers for you to clarify the issue, and then I will conclude my remarks. So this first paper, the one that appeared last month, comes here from Florida. And these authors from Moffitt Cancer Center looked at 105 patients with branch duct IPMNs who underwent endoscopic ultrasound and resection. So here is the interesting part. The likelihood of invasive cancer was 12% in cysts less than 2 centimeters, 48% in cysts 2 to 3 centimeters, almost half of them, and 43% in cysts greater than 3 centimeters. Now, for all of those of you here who love endoscopic ultrasound and that think that this is going to be the answer, of all those patients, remember, everyone had EUS and resection. Of those who had cancer, EUS only picked half of the cancers. So endoscopic ultrasound is not going to be the answer to tell us if there's cancer or not. And here's the big paradox of this paper, and this is why things need to be read carefully. Less than 2% of these, all had endoscopic ultrasound, had nodules. And yet, 77% of the patients who had invasive cancer had stage 2A or 2B. Now, the last time I read the staging manual, a T2 cancer is 2 centimeters or greater. So how can you have a 2-centimeter adenocarcinoma of the pancreas and no solid component on endoscopic ultrasound? So this just doesn't fit. And it doesn't fit also because, these patients, I think 30% presented with jaundice. To present jaundice, you need to have something, some meat in there. This is not just a little innocent, incidentally discovered pancreatic cyst. And my question to them, are these concomitant ductal adenocarcinomas? We know we can resect a ductal adenocarcinoma like we do every week in our hospitals. And by the way, there was a little branch duct IPMN close to it or a little bit far from it. And this is obviously a different beast than the incidentally discovered cystic lesion. And the other paper is the one that comes from Heidelberg. And this is also a very provocative paper. These authors look at 123 resected branch duct IPMNs over about 6 years. And 69 of them were Sendai negative. Now, they published this in 2012. They were using the 2006 guidelines. So Sendai negative meant less than 3 centimeters, no nodules, no duct dilation, and no symptoms. The mean size of these 69 Sendai negative cysts was 1.7 centimeters. And check this out. The range was from 4 millimeters to 2.9 centimeters. So in Heidelberg, you can have a 4-millimeter cyst in your CAT scan, incidentally discovered, and that could prompt a resection. And they have the reasons to do that. I'm not making light of it, and I'm sure they angst with the management of these things as we do, but that's what it says there. Well, 25% of these Sendai negative cysts had malignancy, 16% invasive cancer, 9% high-grade dysplasia. And here is the other thing that I can't understand. The likelihood of malignancy was actually inverse to the size. So it was less than 1 centimeter, 25%, 28% in between 1 and 2 centimeters, and 18% in 2 to 3 centimeters. So there's something that is completely disconnected from what we see. In fact, these authors conclude, this is in their last paragraph, surgical resection should be recommended in principle for all patients with branch duct IPMN. So I tell you here, we know the literature, 10% of 70-year-olds have a cyst in their pancreas. You go and get an MRI or a CT scan for whatever other reason, 10% of 70-year-olds will have a cyst, on average size 8 millimeters. All of us here will be operating non-stop to remove all these lesions. We would probably kill a lot more patients than certainly we would save, we think, but this just doesn't fit. It bothers me a little bit that these authors give no data on tumor staging. So these invasive cancers, what were their stage 2, stage 3, what were the size of their tumors? There's no data on patients being followed, even though they start talking, oh, we follow the Sendai guidelines, but yet we operate on some patients. So what has happened to the patients you follow and how you decide who you follow and who you do not? And again, are these concomitant ductal adenocarcinomas? So there is a big danger if you tell your pathologist, run your database and tell me anybody who's got a branch duct IPMN and spit them out so I can analyze them. Well, yeah, but you can have a branch duct IPMN with an ampullary cancer. You can have a branch duct IPMN with a neuroendocrine tumor. You can have certainly a branch duct IPMN with a ductal adenocarcinoma. We know that because we've seen it in our experience. So I think this is the difference. So in summary, in conclusion, I want to tell you there's little debate regarding the management of mucinous cystic neoplasm and main duct IPMN. These should be resected for the most part. But of course, we take care of individual patients. We don't, this is not an algorithmic thing. The management of branch duct IPMN is still in flux. As you can see, there is no universal consensus on who needs resection. In my opinion, the old guidelines are safe, but many benign tumors are still resected. So we need to make progress in this. The new guidelines need evaluation. We're going to present our experience in a few weeks in the American Surgical regarding the new guidelines. And the take-home message is increasing detection of these lesions is problematic. And we will need guidance, not so much onto who resect, but how often and for how long to follow these patients. Because as our healthcare system is going broke, this is going to cost us a lot of headache and a lot of money. Thank you very much.
Good morning. So, pancreatic cancer obviously doesn't pick the weak and the infamous, and I mean, pancreatic cancer is a is a problem for all of us. We're all potentially victims to this disease. And, a lot of these particular individuals had roots in Indiana. And so I just, wanted to set the proper stage here. I love this slide because for two reasons. One is obviously it's kind of dismal, the pancreatic cancer survivors room, and there's nobody in it. But the reason I like it is there's two windows here, two windows of opportunity to make a difference. And we're all looking for a cure, and that's a important step somewhere in the future for some scientist to discover. But in the meantime, the low-hanging fruit is to find people at risk for pancreatic cancer and screen them and take this very seriously. So there's really two groups: patients with pancreatic cysts and patients with a family history of pancreatic cancer. And these are really the two windows of opportunity for early detection, prevention, and cure. So essentially, with cysts, we're talking about sort of the functional equivalent of polyps in the pancreas, although for obvious reasons we can't put a colonoscope in the pancreatic duct and just resect them like we would in the colon. And essentially, the whole problem here is that we want to intervene before invasive cancer develops. We're going to see a lot more of these polyps than we probably should take out. But still, I mean, the problem is to try to intervene before invasive cancer develops. So if you could figure out when people turn to high-grade dysplasia, that would be the time to remove these, and probably not before. So the international consensus guidelines, I think, are good. I participated with Carlos in those, but I'm going to poke at them a little bit now for the purposes of sort of setting the stage for international consensus guidelines 3, 5 or 6 years from now. So essentially, there's probably the single most important aspect of the guidelines is the differentiation between main duct and branch duct disease, as is seen in the first. Clearly, patients with main duct disease appear to almost have a different biology. So, the chances of cancer in main duct disease is much higher than in branch duct disease. This is just our data here at Indiana. But that doesn't account for everything. Obviously, that leaves the branch duct patients again, which Carlos said are really the most interesting and the most prevalent. When we look at size, really across the board, whatever category you look at, less than 1 centimeter, 1 to 3, greater than 3 centimeter, the incidence of invasive and malignant disease is pretty much equivalent in our series and many other series. So we really can't look at size. The guidelines have de-emphasized size, which is important, and really the emphasis on size in any way and form at this point in the guidelines is just to determine whether or not they can be biopsied. Mural nodule incidence, 30% invasive. You're going to miss a lot of them with this. Cytological atypia, 50% of the invasives and 30% of the high-grade dysplasias will pick up. So, clearly, this is not perfect. And Carlos has already gone over this, so I'm going to sort of move on. So, this particular slide does not incorporate all the patients we saw initially and decided they needed an operation by the international consensus guidelines. But here's the patients that we decided, hey, let's watch these patients. Primarily, that means they never had an operation, or let's watch them secondarily, they had a Whipple or a distal and we're watching their remnant pancreas. So we operated on a number of these patients for a lot of the consensus criteria. They had a main pancreatic duct that, gradually got bigger. Their branch duct size drastically increased, and, in terms of the old guidelines, the size, approached 3 centimeters or went over 3 centimeters. They had a mural nodule. They had new or worsening symptoms. The patient just said, "Doc, I want it out," regardless of the guidelines, or they had concerning cytopathology. So in terms of primary surveillance and secondary surveillance, you can see how this sort of stacks out. And then basically here was our pathology. So 70% or 96% in the primary and 70% in the secondary. When we took them out, they were low grade. So obviously we were still too aggressive in this. We found a few malignant IPMN, and so, not everybody got an operation that actually ended up getting a malignancy. And as you can see, I've just sort of created a table here of our primary and secondary follow-up, which patients had international consensus criteria. There's a lot of nones here until you get down to the 7th or the 8th and 9th patient here. And, the pathology, either malignant or invasive, the stage, whether they got a resection and whether we cured them. So really, it's complicated. It still is complicated. And, we're, even with the consensus criteria, we're still struggling in many cases to do the right thing. And then, here's the tragedy of it all. So here's, 12-month follow-up on a primary surveillance patient. Look, little side branch IPMN here, maybe some little stuff down here. A patient that you're like, give me a break. I'm seeing this patient in clinic as a surgeon. Next visit, 18 months later, if she's on a 6-month protocol, you got a cut off of the duct now, and you got a mass there. And we're thinking, oh, well, it's resectable. And then you look at the other cuts, and she's already got liver mets. And, time marches on. So, some of these young patients that are going to be surveyed for a while, you look at 5 years, 10 years, you hear it all. There's several other publications that sort of look at this. I mean, eventually, the odds get higher and higher that they're going to have a cancer. So all these consensus criteria really, I mean, they're good, and they get a lot of patients initially, but, when we go to follow patients, they're really not optimal, and we need to look for more accurate markers to guide our surveillance. So anyway, that's the preamble for looking at, genetics and biology of these cysts. And so what do we have currently, and what are we going to look at in the future? So the future guidelines, I think, will all be about cyst sample, fluid analysis, and determining genetically and biologically what these cysts will do, and that will dictate then how we will treat them. So currently we can look at CEA, and I'm not going to go over Bill Brug's studies too much here today. All of you are probably familiar that 192 nanograms per mil is the cutoff, and if it's over that, it's likely to be mucinous. If it's under it, it's likely to be non-mucinous. There's a company in Pittsburgh, Redpath, who looks at a molecular profiling of these cysts, and I'm going to show you some new data out of a registry of 9 institutions looking at this that's rather interesting. And essentially, they're looking at malignant potential as well as some diagnostic aspects with looking at the KRAS. And then we'll sort of dial into the future here and see the GNAS mutation is actually available through the Redpath company at this point, but most of this other stuff is up and coming. So what about this PATHFINDER TG? I mean, essentially, right now it's really the only CLIA-approved test which measures malignant potential in cysts. And the test is based on several different factors, DNA quality, quantity, whether there's a KRAS mutation, and then a number of loss of heterozygosity mutations, which actually they don't look for the mutations per se, but they look for microsatellite instability at these loci, so multiple pancreatic cancer gene loci, SMAD4, P53, and then novel loci that they've discovered, like one on 17q, which is important to remember because that'll come back and be relevant later in the talk. And then, what the clonality of the mutation is. So this is new data, and it's a moving target because we've got 9 institutions that are compiling data just looking at molecular analysis with this test. And essentially, we're at 256 patients at this point, and there's different criteria. I mean, there's some of them are surgical patients. You'll see here, you've got surgical outcomes in 105, and some of are clinical patients. So this combines the clinical outcomes in terms of, years of follow-up. But just focus on the interim survival analysis here. So, the green and yellow bars, and I know it's small, but I wanted to get a lot into this talk. So, but the green and yellow bars are really the patients that the test indicated were indolent or benign, essentially on the low side of indolent. And these other bars here which measure the incidence of malignancy, essentially, or not having malignancy, rather, are the statistically indolent high or the aggressive. And so, I mean, it's a pretty impressive survival analysis or lack of malignancy analysis going forward. And, you know, we're only at 256 patients, but with the input of the other sites, you know, we expect to be over 500 patients within the next 6-7 months. If you're interested in participating in this, you know, the more patients we can get into this registry, the better. This is sponsored by the RedPath company, I will say, but it's run by the institutions that are putting the data in. So what about this GNAS? So guanine nucleotide regulatory proteins, this particular one is the GS alpha protein, and essentially this was discovered with a collaboration with Memorial, Hopkins, and Indiana, pooling our cyst fluids and having a scientist, Bert Vogelstein, and his team look at these at Hopkins, and essentially whether it was tissue or fluid, they found there was a GNAS mutation in 61% tissue-wise, 66% fluid, and essentially this was diagnostic of IPMN. So if patients have a GNAS, you know, I mean, 100% of them had IPMN on surgical pathology, not MCN, not, I mean, and so they looked at, you know, all the other different diagnoses, and there's nothing there present. So this would be highly useful. You know, I call it a diagnostic marker, but clearly if you knew it was an IPMN, you know, this could tell you something at least about the biology of the disease. If it's KRAS, you know it's either an MCN or an IPMN. But with GNAS, it appears virtually diagnostic. Now, this hasn't been repeated, probably needs to be repeated, and we're in the process of doing that now on a much larger scale. This test is available through RedPath at this point as a separate item on top of their PATHFINDER TG. I think it costs an extra $40 or something like that to do that. So now, what about ubiquitin-dependent pathway mutations? So this, importantly, this data is just in tissue. So this hasn't been confirmed in cyst fluid yet, but it's very exciting. So essentially using this next generation sequencing, this whole exome sequence, you know, it took a decade to sequence the whole genome, and it was a huge project, and now we have a little machine that's like this big by this big that can sequence it overnight. So essentially we used one of these next generation sequencing machines to figure out this data. And essentially, we're looking for loss of heterozygosity actual mutations, and the von Hippel-Lindau gene here came up as present in serous cystic neoplasms, and the RNF43, both related to ubiquitin, ended up showing up in the mucinous cystic neoplasms and IPMN. I haven't shown one other one here, was in solid pseudopapillary neoplasms. But essentially, these are present in the tissue. You know, the next step is to try to figure out if these can be identified in the cyst fluid so we could, you know, create a test that could identify these. But again, these are specific. You know, the serous cystic neoplasms are the only ones that express the VHL mutation. And the RNF43 is only in mucinous cysts. So stepping away a little bit from genetics, you know, genetic tests are expensive. They're a little bit more complicated to do. Is there any simple, really simple tests that might be done to sort of put people in different categories? VEGF, it's a ubiquitous molecule, but a specific isoform of VEGF. If you look at it, it is present in serous cystic neoplasms at a certain threshold level, and it's very logarithmically much lower in other neoplasms. So essentially, it distinguishes serous cystic neoplasms. I would say at this point it's not 100% sensitivity specificity because we have found one outlier and trying to predict the need for resection. So as surgeons, high-grade IPMN, pancreatic neuroendocrine tumors that are cystic solid pseudopapillary neoplasms, we're probably going to take those out unless it's prohibitive risk in these patients. Whereas the low-grade IPMN and serous cystic neoplasms, we aren't. Using their microRNA profile, they had an 89% sensitivity, 100% specificity in terms of predicting what you should do as a surgeon. This is amidst trying to be confirmed prospectively with just EUS-derived cyst fluid. We're participating in that, and stay tuned. So what about IPMN subtype? So it turns out that there's actually specific antigen markers within the cyst fluid that can tell you whether or not you're dealing with an intestinal type, a gastric type, what sort of subtype. Now, as time has gone on, this sounded like a great idea initially, but as time has gone on, the subtypes, one isn't necessarily bad and the other's good. And so, determining this may or may not help us in the long run. But essentially, with the fluid, we're finding that, with specific antigens that we're able to discover, that we can predict before the specimen's out what type of subtype you have. And if you're a believer in subtype predicts biology, then this is potentially going to be helpful as well. So just to review, so again, the future holds, diagnostic capabilities, looking at IPMN, serocystic neoplasm, a couple different tests for that, a mucinous cyst based on the RNF43. We didn't talk much about this, but the CTNNB1 is a solid pseudopapillary neoplasm specific test. Again, these latter two are just in tissue now. We're hoping to confirm that we can pick those up in the fluid. And again, some of the other types of non-genetic tests, PGE2, miRNA, and the IPMN subtype. So this is a nice take-home slide for you to sort of look into the future and see where we're going to be when we can wrap all this into a single test. Essentially, if you have a GNAS mutation, you've got an IPMN. If you've got a KRAS mutation, you're going to be in the mucinous category. If you have an RNF43 mutation, you're going to be in the mucinous category. Solid pseudopapillary neoplasm is just the CTNNB1 category, and then the serocyst and the von Hippel-Lindau mutation in the serocyst. And then in terms of looking at biological behavior, clearly, this chart dictates some biological behavior based on the diagnosis alone, so I don't mean to separate those artificially, but you've got the PATHFINDER tests, which will be, helpful in discriminating the different mucinous lesions and their risk, possibly the miRNA if it can be confirmed, and then VEGF and PGE2 to help as well. So, it's just my idea is that the future will be cyst fluid analysis, and that we won't have to work as hard trying to figure out who needs an operation. So, with pancreatic cancer, why we're looking for a cure, really, I agree with Carlos. This is a fascinating group of patients, and it's a wonderful opportunity to identify, screen patients, particularly the cyst patients, but also people with a family history, to promote early detection and prevention of pancreatic cancer. Thank you.
Good morning. Thank you for the invitation. I have to say that the more and more of these lesions that we see and manage, the more and more confused I get about the most appropriate management for any specific patient. This morning, I'm really going to focus on some basic questions that Chris asked that we address. The three are listed here. Does the size of the lesion matter in patients with branch duct IPMN? What constitutes a solid component or mural nodule? And then total versus partial pancreatectomy for main duct IPMN. And I think this really comes down to what I view as the current challenges in managing these patients. With branch duct lesions, the question is, should the patient have an operation or not? And then in patients with main duct disease, the question that I'm really struggling with right now is what operation should they have? As was summarized earlier, certainly I think that a selective approach to branch duct IPMN is it should be utilized. I actually showed that paper that Carlos showed from Heidelberg to David Klimstra, and our pathologist, and he actually took a look at the histopathology micrographs that were shown, and he said that was just clearly a Pannin lesion next to an invasive cancer. So I think we need to look at some of these reports quite carefully before we jump to any conclusions. I certainly think that we are following the consensus guidelines. I think these are very, very helpful, not only to us as practitioners, but to patients, in terms of getting a feeling that there are large groups of physicians out there who agree with this approach. And I would say that the size of the lesion and the presence of a solid component or mural nodule are the two factors in most studies that have been most frequently found to be associated with high-grade dysplasia or invasive disease. I would also say symptoms such as jaundice, clearly also a factor there. But outside of symptoms, these two factors very consistent in the literature in terms of being associated with dysplasia and invasion. And certainly we continue to find this, and we, as we search our weekly and monthly operative registers, we're continually looking for that patient who presents with this nondescript 1 centimeter branch duct IPMN who for some reason undergoes an operation, because all of these patients had an operation, and was found to have an incidentally discovered invasive cancer. And we've not seen it. We've not seen an invasive cancer in a patient with a small branch duct IPMN that doesn't have any concerning features. And these are not patients who are jaundiced, who have a mass lesion in the head of the pancreas and have a small cyst adjacent to it. But these are patients with incidentally discovered branch duct IPMN. We haven't seen invasive cancer there. Now, certainly, these larger lesions, we are also seeing some associated features there, and it's hard to tease out whether or not it's exactly, is it the size of the lesion or is it other features such as what we spoke about earlier, this mural nodularity or solid component. We've really tried to incorporate multiple factors into logistic regression analysis and develop a nomogram. And when we submitted branch duct lesions to nomogram development, and this is just sort of a beginning swing at this for patients with IPMN, we did see that both solid component and lesion diameter fell into the nomogram. So we would feel that these are independently predictive of high-grade dysplasia and invasive disease. And really the nomogram we're developing is one that tries to separate both low-grade versus high-grade versus invasive lesions. Now, we always struggle, and we're just speaking with Ed at the beginning of the conference up front about, well, what is a mural nodule and what is a solid component to these lesions? And it's tough many times, primarily because of how is it being defined? Is it being defined radiographically, or is it being defined by endoscopic ultrasound? I do think that when it's being defined by either technique, that certainly enhancement is critical. I think that gives us, at least with endoscopic ultrasound, a feeling that this is truly a growth in the side of the lesion rather than mucin that can be picked up and misread as a mural nodule many times. I do think that also when we're talking about EUS, we know that there's a lot of operator dependence there as to the reliability of it. And I do think that the literature now suggests that the size of that nodule by EUS is important in terms of being associated with low risk or high risk disease. And that may well be just the reliability of them being able to identify it. But I do think when we start getting up to larger lesions, over a centimeter mural nodule in this study from Japan, in this study also from the Japanese group, greater than 5 millimeters. So I think when endoscopic ultrasound or certainly imaging suggests a nodule that's in that 8 millimeter to 1 centimeter range, we start to pay attention to it. Again, needing to be an enhancing lesion to really be defined as such. I would like to say that we do continue to take this with a bit of a grain of salt. We had 4 of our radiologists recently review 84 patients who had undergone resection for branch duct IPMN, and we asked them to categorize these lesions based on radiographic criteria that we considered to be important for high-grade dysplasia or invasive disease. Things such as size of the lesion, size of the pancreatic duct, was there a solid component which they really defined as thickening of the wall of the cyst. Was there a mural nodule? These 4 radiologists, 3 of them were attending radiologists, GI radiologists, body imagers, people who are used to reading imaging, pancreatic imaging, and 1 was a fellow. And actually, when we looked at the agreement, looked at in a variety of ways, looking at intra-class correlation and so forth, we found excellent agreement in their ability to measure the diameter. So they could measure the diameter of that branch duct IPMN quite accurately. But when we looked at things such as solid component and mural nodule, there was a lot of disagreement as to whether those findings were present or not. So I think we still need to be very careful when we talk about mural nodularity or solid component and take some of these findings with a bit of a grain of salt. So I would say for branch duct IPMN, we really do feel that size of the lesion does play a role. We also feel that the presence of a solid component or significant mural nodularity is concerning for high-risk disease, and we generally put these people into a resection group rather than surveillance. And we feel that partial pancreatectomy and even enucleation was touched on earlier. I'm not going to go into that in detail. Is certainly appropriate in selected patients. Now, as was mentioned, with main duct IPMN, the decision of whether an operation should or should not be performed, I think, is relatively straightforward. I think most of us would recommend that the majority of these have an operation, and that's because of data from a variety of institutions have suggested that in the presence of main duct dilation, the risk of high-grade dysplasia or invasive disease is significantly higher. The main question, and the question that certainly I struggle with more and more, is what is the appropriate operative approach? Should the patient have a Whipple procedure, distal pancreatectomy, or total pancreatectomy? As in many of these patients, there's really a diffuse disease throughout the pancreas. And just to present a very quick patient who I saw recently, a gentleman with a history of diabetes, but controlled with oral medicines, who had some relatively non-specific complaints and mild weight loss, and had this CT scan. And I'll just scroll through this for you very quickly so that you can see the pancreas and the dilation of the pancreatic duct here in the center of the pancreas, really extending all the way into the head of the gland. And I think you can appreciate that the entire pancreas is diseased here, with branch duct cystic lesions out in the body and tail, and a diffusely dilated pancreatic duct. And more and more often, we're seeing patients with this type of diffuse disease really throughout their gland. This patient had been referred to a gastroenterologist and had these tests performed. It was characteristic of an IPMN with a diffusely dilated duct. There was a suggestion of a mass in the head of the pancreas. The cytology did not identify a carcinoma. And I think the real question in this patient is, what's the most appropriate operation, as I mentioned on the previous slide. And I think the challenges of the questions here are, is there high-grade dysplasia or invasive cancer in the pancreas? Where is it located? We mentioned earlier about wanting to resect these lesions before they become cancer. So is there high-grade dysplasia throughout the gland? And that will be certainly the challenge for some of these future studies looking at markers. Can they identify where the high-grade dysplasia is located? Or even, and I'll touch on just briefly in a moment, well, what is the subtype of this? And Max mentioned that, and I do think that that can become important. And this is a separate patient who I also saw recently, who you can again see, this pancreatic duct is dilated throughout the pancreas, and even in the unsnit process, the unsnit duct is also dilated here. And these patients, I think, are a real challenge in terms of what's the appropriate treatment. I think to get an idea as to at least where we stand currently in terms of what's the most appropriate treatment, it's very important for us to look at, well, what's the outcome of what we already know? Our general approach, and I think most institutions' general approach to patients with IPMN, and not just specifically the patients with main duct disease, has been partial pancreatectomy. And some of these patients will have invasive cancer, and some will have non-invasive cancer. And I think it's valuable to look at the outcome of these groups of patients to see whether or not total pancreatectomy or partial pancreatectomy would be more appropriate. To look at the patients who undergo resection for invasive cancer, certainly some of the early reports out of Hopkins as well as out of our own institution suggested that patients with invasive IPMN had better disease-specific outcomes than patients with invasive conventional pancreatic cancer. And certainly more recent studies, however, I think suggest that the outcome in specific subtypes of IPMN is very similar to conventional pancreas cancer. This is a study actually that Chris Wolfgang and George Polsides published out of Hopkins. And again, you see this suggestion here that patients with IPMN-associated cancer may have better outcomes than patients with conventional cancer. However, they importantly noted that these patients with invasive IPMN are generally found with earlier stage lesions. And there are certainly two specific histopathologic subtypes of invasion, this colloid cancer, which at least in historical studies had been shown to have improved outcome, versus the more conventional tubular subtype. That study actually really prompted Adam Yopp at our institution to do a matched analysis of IPMN and conventional cancer, where we really wanted to look at the staging, and we matched for T and N stage, and then we carefully looked at tubular versus colloid subtype, because we did feel the literature was fairly clear that the colloid patients tended to have better outcome. Roughly half of the patients who undergo resection will have this invasive colloid cancer, and I do think that although IPMN is relatively unusual, roughly half of these patients will have colloid carcinoma. Again, when we looked at survival, this is the survival curve of all patients who had undergone resection for invasive IPMN, again suggesting a favorable outcome in this group of patients, with colloid patients doing quite well. 5-year survivals in this group approaching 90% for invasive colloid cancer. These are the invasive tubulars, and when we actually matched those patients with conventional pancreatic cancer patients by stage, we actually found almost identical survival outcomes with the patients with invasive tubular IPMN versus conventional cancer. So although on the first blush this looks like a better survival curve, we believe much of this is due to a very early stage at diagnosis for invasive tubular cancers. So with regards to these outcomes, we do feel that the outcome in these patients, as the majority of these patients will succumb from metastatic disease, is really dependent. This disease-specific outcome is really dependent on the development of distant disease rather than recurrence within the pancreatic remnant. So we do feel that partial pancreatectomy for the vast majority of patients, when you suspect an invasive cancer, is the most appropriate approach. These colloid subtypes may be outliers in certain instances, but we do feel that in general it's really that the distant recurrence that determines long-term outcome in these patients, and not in-gland recurrence of IPMN. To shift now in terms of, well, what should we think of in terms of patients with non-invasive disease, and this is this concept of the pancreatic remnant. Partial pancreatectomy in the setting of main duct IPMN does leave pancreas that is at risk, and we certainly feel that in some patients this risk could be significant. The question is, well, what is that risk exactly? And certainly in the majority of studies that have been reported, this risk with relatively short long-term follow-up is about 8 to 10%. And this is a table that looks at gland recurrence in patients who've undergone resection. Many of these studies have included patients with invasive disease, and I think for the reasons that we just pointed out, that those patients should probably not be looked at seriously in terms of gland recurrence. This is a paper that Rebecca White published out of our institution back in 2006, looking at gland recurrence in partial pancreatectomy for non-invasive cancer, and again, relatively consistent results, that with median follow-ups in the 3 to 5 year range, we're seeing gland recurrence in the range of about 8 to 10%. Certainly, we feel that risk factors for this gland recurrence are really not only margin status, which Tim Frankel presented here yesterday, but also a degree of dysplasia, and that patients with high-grade dysplasia in that partial pancreatic resection specimen appeared to be at higher risk for gland recurrence. This may well just reflect an overall status of progression within the pancreas and suggest that, well, indeed, maybe high-grade dysplasia, if it's present in the head in a patient with main duct IPN, may also well be present in the body and tail. We do think that because this risk is relatively low, that total pancreatectomy should really be reserved for very select patients. And in general, we're still considering partial pancreatectomy. This is generally a Whipple procedure. However, in patients who have significant disease in the body and tail, certainly a distal pancreatectomy splenectomy may be the right approach. So just to summarize that, we think that in resection for invasive IPMN, distant disease recurrence is the driver of long-term outcome. Certainly, the invasive subtype also thought to be important, with colloid patients having a significantly better long-term disease-specific outcome. In patients who undergo resection in the setting of non-invasive disease, these are the patients where we're thinking about gland recurrence. High-grade dysplasia and a positive resection margin are certainly things that we found to be associated with that. However, I would say that in patients with a high likelihood of invasive disease, we generally would consider partial pancreatectomy, and certainly in the absence of overt signs of invasion, partial pancreatectomy is generally favored with resection of the most concerning regions of the gland. Total pancreatectomy, we certainly are performing in the minority of patients, and these are generally patients with extensive whole gland disease, similar to the patient who I showed in the case, or patients who do not have a clear dominant focus or an invasive component. Thank you.